Welcome to the Dutch Podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jacqueline Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. The information is not to be interpreted as or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, or treatment.
On this week's episode of the Dutch Podcast, I get to talk with Dr. Kyle Gillett. Now, Dr. Gillett has built a practice on hormone balance for men and women with a special focus on fertility. And I'm excited because today we covered a topic that we don't always talk about with fertility, which is men and the importance of male fertility. There's been a lot that's changed, even just around the paradigm of whether men should be tested and how men should be tested. And I really think Dr. Gillett's perspective is a forward-thinking one that you're going to appreciate. We also get a chance to talk a little bit about hormone optimization, the importance of testosterone, and really one thing I really appreciate about Dr. Gillett is his focus on root cause hormone optimization. Now, this is an area that's commonly overlooked because it's so easy to just prescribe hormones when hormones are out of balance. But really, we have to look underneath the hood, figure out what's actually going on with patients. And you can really be a better provider for your patients if you dig a little deeper to figure out where the problem is starting from instead of just treating with hormones. So let's go ahead and dive in. Well, today's guest is Dr. Kyle Gillett. Dr. Gillett's practice includes preventive and integrative medicine, sports medicine, hormone optimization, and infertility, amongst many other topics. He really believes each human is a unique creation that requires attention to their body, mind, and soul. He firmly believes in the concept of food as medicine and exercise as medicine, and believes they're more powerful than any medication or supplement. I think you're going to find a community of like-minded people here today. So anyway, Dr. Gillett, really glad to have you. Thank you so much for joining me.
My pleasure. Thank you.
So before we dive into kind of the meat of the podcast, I always love to ask, because I find it so interesting when you have a conventionally trained provider who moves over more into the integrative space. Can you share a little bit more about your backstory and what led you down this path?
Certainly. I'm from Kansas, as many people know, and I was homeschooled, and my brothers were as well, all the way through when we grew up. So I've always been a very open-minded, critical thinker. And my father is a family physician, and as is in the Midwest, family doctors do quite a bit. Deliver babies. I've delivered hundreds of babies. And, do lots of procedures and do what we call full scope or full spectrum family medicine. And as I grew up, even when I was 12, I knew I wanted to be a family physician and practice holistic medicine. I'm a Christian, my family is as well, and we've worked for a faith-based practice. And I watched the practice that my dad helped grow start to struggle and be taken over by a large hospital system. It basically just got too large. It was very successful. But as insurance models changed, I saw that even though the doctors really cared for their patients, body, mind, and soul, they were very unhealthy. And a lot of times the lifestyle interventions is what lacked. And I also saw, it's partly just a business problem. Supply and demand. The demand for hormone pathology treatments, whether it's fertility or menopause or low testosterone, is extremely high. And that demand was not able to be met with high quality, evidence-based healthcare providers. So I tailored my education to do this. And as I went through the conventional medical system and went to the University of Kansas for medical school and an unopposed residency, which basically just means we're the only residents. So we got all the experience in the ER, all the experience in labor and delivery unit, et cetera. I noticed that, lots of people are interested in food as medicine and exercise as medicine, two of the most popular interest groups. But hundreds of people told me, don't go into family medicine. Don't go into obesity medicine. You're wasting your education. So I'm a good test taker. And they said, be a surgeon. Be whatever has the highest average salary. But the hardest thing to do is really good full spectrum medicine. That's what functional medicine is, addressing the root cause. And it's very difficult. But unfortunately, we send our, students that struggle to even pass tests into family medicine and psychiatry, which is another completely different topic. But I was determined. So I wasted my education according to almost all of my colleagues and, mentors and whatnot, and went into family medicine. And then I knew that at the end of the day, I wanted to do concierge medicine and, holistic medicine, just like this. So I was one of the lucky ones. But I do know that partly thanks to podcasts like this, lots of pre-meds and medical students are very interested in this, even in the conventional system.
Hmm. It's great to hear that. It's interesting because I had looked at conventional medicine as well and chose naturopathic specifically because it was a primary care focused curriculum with lifestyle medicine included. And um, yeah, it's interesting people that tell you that you wasted your education on it because ultimately our system's not built for success of an effective model of family medicine in the modern day healthcare system, but it's so imperative that we fix that because obviously this top end, medication procedure focused care isn't enough. It's not protecting the health of our communities, that's for sure.
Yeah, that's certainly true. And, even 5 or 10 years ago, I would call most general practitioners algorithm robots. And now that I've designed a couple AI robots of myself and an AI doctor, I think that their jobs are quite literally going to be taken by, hopefully, my robots. But I do think that this opportunity, it's glass half full, if you will. It's an opportunity for people to rethink their careers and have more time to address root cause medicine.
Yeah, absolutely. Well, I want to talk a little bit about hormones because I know that's been a big area of your focus. Tell me about the top conditions that men and women come in to see you with this hormonal focus.
Yeah. For my specific practice, still probably one of the number one things is fertility. But with my, clinic entirely, which is 4 physicians and 4 nurse practitioners and 2 dietitians, and we've had, physiotherapists. We have an academic center without the red tape, if you will. The most common is PCOS. So it used to be that far more than half my practice was female. And part of that, again, supply and demand. At some point, menopause occurs in each female. So that's also relatively common. But I will say that since I kind of have been seen as a hormone specialist, I have more zebras. So for those that aren't familiar, we always say in medical education, when you see most things happen, you're in a field in the United States, it's usually going to be a horse, but every once in a while it's a zebra. Those are rare diseases. So I do have um, way above my, per capita rate for Kalman syndrome or hypothalamic amenorrhea or things that just aren't as common, congenital adrenal hyperplasia, all sorts of rarities like that.
Keeps life interesting, doesn't it? When you get that specialty um, reputation out there, definitely the tougher cases come your way. And I'm sure you can handle them too, which is great. Well, let's start maybe by talking about fertility. I mean, we have fertility affecting men and women. Rates are really increasing. This has been the primary focus of my practice for 20 years as well. I want to start by talking about male factor infertility because this is an area that's gotten more recent attention, but is really, I think, oftentimes overlooked. And I think socially and culturally, fertility is a condition most often managed by the female partner in a heterosexual relationship. So tell me a little bit about this gap in male fertility. Let's start there. Male fertility assessment, evaluation, treatment.
Yeah. So male fertility is a lot more than just what is your sperm count. Although sperm count is important, the statistics are true. Sperm counts are decreasing for a variety of reasons. Yes, metabolic syndrome is one of the main reasons. Yes, even things like sleep apnea is a major reason for declining sperm counts and sperm motility. Poor diet is another reason. Plastics are a reason. It's kind of difficult to say, you know, what percentage of that is causing it, but it is something to consider. And even things like medications are reasons. So I like to say for males, when you're attempting conception and 3 months or even more before conception, pretend like you're pregnant. But instead of, avoiding deli meat, which probably isn't even that important, instead of avoiding alcohol during pregnancy, avoid alcohol pre pregnancy. instead of avoiding um, you know too much caffeine during pregnancy. In the 2 to 3 months that it takes to make a sperm, you should avoid things like metformin, the medication, excess alcohol. This is as a male, when you're attempting to conceive, or even when
Mhm.
you might conceive. And I think a good case can be made that you should avoid selective serotonin reuptake inhibitors, SSRIs, and also medications like finasteride or dutasteride, mostly just because of theoretical epigenetic concerns. But they can also change something called intratesticular testosterone. So, without getting too much in the weeds, this 2 to 3 month period, plus however long it takes to actually conceive, if there is a very healthy couple under the age of 30 and there is no fertility issues, then there is a less than 50% chance that you become fertile the first time. That being said, there's also reasons like varicocele that are common reasons why you might have slightly less fertility. But in all cases, there's at least three things that can be improved and optimized. I do think that for people who might be thinking about conceiving a child, even if there's no issue expected, it is reasonable to do these home fertility tests. There's many of them, and they continue to get better and better. That way, you get a baseline, just like I recommend baseline labs for people when they're younger. The last thing I'll say about this is, people always think about female age and fertility, but male age and fertility also matters, not just because of microplastic accumulation in the gonad, which is the testicle in the male case, of course, but on average at age 20, fertility is going to be significantly better than age 40 for males as well. So that's one factor to consider.
Yeah, it's such an interesting transition, I think, because I remember even 5 years ago, and even now, probably some reproductive endos and reproductive urologists, they think sperm doesn't matter. It's like, oh, men don't really need to have a lot of sperm. You only need one, and they make millions. So, we can even do ICSI and just get that one sperm. But the paradigm seems, or the conversation seems to be starting to
Hmm.
shift a little bit, where it's like quantity is a represented, like a kind of an analogous representation of quality in a lot of ways, not always, but often. And so, should we be thinking about sperm quality as well?
Yeah, definitely. And I recently had this conversation on the Gillett Health podcast with Dr. Jake Fantis. He's also from the University of Kansas, and I like him a lot, so I'm very biased. But he is basically a reproductive and infertility urologist. And he serves on a lot of the same AUA boards as Dr. Kara, who I know has done the podcast as well.
Mhm.
And Dr. Fantis does a lot of clinical research on fertility, including things like FSH. And, should we be treating men with idiopathic infertility, which is actually pretty rare, with things like FSH, the hormone? And one of the questions that we posed is specifically for people who have been on something like TRT, not necessarily injecting TRT, how people think about, but maybe people who have done clomiphene or people who, took some supplements that had something called Superdrol in it that used to be for sale over the counter at GNC. Maybe they don't even know that they did that. And we've noticed this trend of people starting with, say, 300 million sperm, and they can recover their fertility. But it does seem that after some of these treatments or therapies, or just people take these over the counter supplements or SARMs, that it's very difficult to get it much over 100 million. So there's something to do with a complete recovery versus a adequate recovery. So I think that um, a lot of urologists that specialize in infertility are thinking about these questions, but unfortunately, we're probably 10 years away from having excellent therapies for this. And in my practice and also in his practice, we've seen phenomenal results for basically males that are not fertile or not fertile enough that have not responded to something called HCG, which is human chorionic gonadotropin. And they often do respond when FSH is added in.
Yeah, that's so interesting because I think, especially now that men are thinking about their androgens and testosterone younger and younger, this could potentially become an even bigger hurdle. I mean, I see a lot of men, and actually the supplement industry, I'm glad that you bring that up because like the muscle building kind of anabolic weight management and muscle building supplements are the dirtiest category. And I've spent a lot of years in the supplement industry, specifically around dietary supplement quality and testing. And that's an area where there is a huge burden of contamination and adulteration that men may not even know they had, like you said.
Yeah, that's true. Some examples, as perhaps you've discussed before, is most of these gas station erectile dysfunction or sexual health supplements. Most of them have something like a Viagra or Cialis in it. And then a lot of muscle building supplements just have pro hormones or SARMs, which basically bind the androgen receptor. It's basically a type of synthetic hormone replacement therapy that
Mhm.
people are on without knowing about it. So it is a pretty major concern.
Yeah, and these are even things that you might today buy on Amazon and I think the challenge is even some of the trusted brand names are being there's dupes being sold. So you got to just be very, very careful with where you get that stuff. If you're a man thinking about purchasing, probably don't buy your supplements from a gas station. That's like the number one recommendation there. So let's talk a little bit about. I love how you said that you recommend that men, or it's reasonable to recommend that men do a little bit of a screening if they're thinking about conceiving. Do you typically start with like an at-home semen analysis, or what would you think about including in that?
Yeah, the first step, as in any other step, is doing good lab tests. So, for most males, this is not going to include, 17 hydroxy progesterone levels, but in all males, I do really like to get a serum sex hormone binding globulin, which it's basically a protein that binds all estrogens and androgens. And this is particularly important because the more of it you have, the more your body is going to be better at uh, pushing androgens like testosterone inside the testicle to provide fertility benefit. So, this ITT or intratesticular testosterone level is very important, and there's many ways that we measure it as a proxy in various studies. But that this is one good start to it. And then, of course, you're going to find your metabolic syndromes, your insulin resistance, which is very important, and an LH and FSH, which is two hormones that come from the pituitary and cause the testicles to make testosterone and sperm. And they actually both have benefit to produce, some. But basically, when they bind the receptors, the LH receptor and the FSH receptor, both of those have benefit for testosterone production, and both of them have benefit for sperm production. However, FSH is primarily important for sperm production. And there's a lot of these different basically on and off switches, and many things throughout the body can cause that to go on or off. For example, a very high estrogen. If a male is higher body fat, then estrogen will cause one of those off switches to come on, and you will not have as much LH and FSH as you otherwise would want. So, this lab test can detect a lot of issues before they occur. It'll also check things like prolactin, which is another off switch. After that, I do like home fertility tests. I, there's actually several good brands. So I won't.
You can talk about them. People always ask, so feel free to share the brands that you recommend to patients if you're comfortable.
Yeah, the two major ones are Fellows and YO, and they both have good home fertility tests. There's also Give Legacy. So Give Legacy does not use an at-home analysis. The nice thing about Yo is that they ship a box, and now you can get a concentration with their updated model. The Give Legacy does also offer testing for infectious diseases. There's ones that are sexually transmitted, there's ones that are not sexually transmitted that affect fertility in both males and females. But that's one nice service that Give Legacy does offer for someone that might not have access to a physician to order those tests. So those are kind of the three main ones. The one that I have personally used, people have heard me talk about my fertility journey, which is not as difficult as it seems. I have 3 children. It's just that I had bilateral varicocele before having kids or whatnot. So it made sense to me to test it before, during, and after. And we've had, fortunately, been blessed with excellent success. But I do use that Yo home fertility test personally, although I know that Dr. Fantis likes the Fellows test, and a lot of physicians like Give Legacy because you're sending it in rather than using a box at home.
The box at home, you have to self-analyze, like counting your own sperm. How does that work? Or does it report something digitally to you? I'm
Yeah,
curious about this because I haven't seen those
it's a
two.
good question. So it's a little bit like a chemistry experiment. You take the sample and then you put a little bit of powder in it. And the powder helps it basically go into solution. The more liquid it is, the easier it is to analyze on the slide. And then you take the
Mhm.
pipette and drop it on the slide, just like you would you know, looking at a slide in, biology class. And then you put the slide in the little box, and the box does all the analysis. So you don't have to count,
Okay.
motility, progressive motility, morphology. It does all of that. It's obviously not perfect, but it does give you a motility and a concentration and a count. I call it a qualitative test.
Yeah, that's great. I mean, these are probably not intended to be diagnostic the way it would be if you were, it's more educational versus diagnostic tool. Like if you sent it to a fertility clinic, the clinicians or the scientists who do the analysis have extensive experience in being able to tell the difference between like head shape deformities, for example, that are so subtle. So it's nice to have that at home example and not have to be that level of expert. What do you think about DNA fragmentation testing, which I know Give Legacy offers? Does that add additional value in the assessment?
It does. So I do occasionally order DNA fragmentation testing for those in younger age categories. For older age categories, classically, you do the DNA fragmentation testing, and I don't think it's a strict cutoff. So some people say 40%, 50%, it just kind of depends. But basically, for people who aren't familiar, DNA fragmentation testing is exactly what it sounds like. It's looking for DNA damage, which is more likely to happen as age progresses. But let's say you have an airline pilot or an X-ray technician, especially someone like an airline pilot that has slightly higher than normal radiation levels, or maybe someone has been exposed. Maybe they worked in a nuclear power plant, or they lived in a basement without knowing it that had very high levels of radon for a long time. Even if they're 22 years old, then I think it's the more chance that there is that DNA fragmentation has occurred, the more I am apt to order it. And the more trouble there has been with fertility, the more I am apt to order DNA fragmentation as well.
Yeah, cool. So talk to me a little bit about the use of Dutch testing when it comes to hormone analysis. Like if you start with serum, when do you think about adding Dutch testing versus utilizing serum alone?
Yeah, I do like to do them at the same time. So the people listening to this podcast are probably fairly familiar, but Dutch testing can tell you a lot about the enzymatic processes that have happened upstream. So you're looking at depending on if you're doing a cycle map test, you're kind of looking at a real time example of what the various metabolites have been. A good example is there's a female who is seeing me for fertility, and maybe they're already doing some tests like a Myra test. There's a bunch of tests people are probably familiar with, and there is lots of decent ones, even just home LH test strips. But maybe they're testing glucuronidated estrone in the urine, but that just tells you what glucuronidated estrone is. It doesn't tell you what your estriol to estradiol to estrone ratio is. So maybe your estrogen is actually not peaking that high, but you just have a lot of estrone in your urine. So the Dutch test is great to run concurrently, to get an idea, again, in real time of what the enzymatic processes are. Another great use of a Dutch test is for people who are wondering, like, let's say somebody's on dutasteride. I'm currently on dutasteride. I'm not on my fertility protocol. And perhaps they want to get fertile and they don't want to trust just a serum DHT that's returned to relatively normal. You can look at what's happened in regards to 5-alpha reduction for your androgens, which is testosterone, and your progestogens. So you can get an idea, kind of double checking yourself, how much 5-alpha reduction is really occurring. So in this case, you would want someone to be back to normal in their terms of 5-alpha reduction. And those are, there's a lot of other cases of when it can be helpful, but there's not a lot of alternatives to doing that testing. I think the main thing that I tend to do differently than a lot of providers who order Dutch testing is exactly what you mentioned. A lot of providers, they just get Dutch testing right off the bat, but I do like to get it after or at the same time as other tests for maximum context.
I like that approach actually a lot because you can really see, when we look at serum, you're looking at blood pool, which is how much hormone is available to tissues. When you look in urine, which is the primary sample source for Dutch testing, you're seeing what happens after it leaves the tissues and undergoes metabolism, like you said. So you're really able to get that complete picture of almost the before and the after, which does give you that full spectrum context. So I think the way that you order it makes a lot of sense and certainly can be really, really helpful.
Yeah. One analogy that I use with patients sometimes is patients often wish that they were part of a case study at a big academic center, Mayo Clinic, whatever it is, and that they just, had every piece of information available to know exactly what was happening with their hormones. And that is difficult to do with just serum testing. So I think that would be a great candidate for a Dutch test. And I think that shared decision making also helps. Some people want to know exactly the root cause. I tend to be in that category. And some people want to do therapeutic trials and they don't like doing tests and this and that. So I think it's good to kind of talk through those options with patients.
Yeah, completely. I actually had this conversation last night with a doctor that is in a mentor, someone that I'm mentoring, and she said, she's a newer doctor. She said so many of patients come into me and they want to have their hormones run, but the doctor that owns the clinic doesn't tend to do that. They just want to institute a treatment based upon the symptom picture. But I know that my colleagues are doing it, my competitors are doing it, and the patient will probably just leave and go see someone else who will
Yeah.
run them. Is that a good reason for me to run the testing? And it's like, well, really, no, if you think you can help them without. But there is an element to test, don't guess. And certainly the opportunity to understand what's happening. One, a lot of patients want to understand what's happening. Like you said, they want the root cause. They don't just want a symptom fix. And if you're in the concierge model and it's a cash pay model and you're not billing insurance, you have that opportunity to support the patient
Yeah.
in that way,
At the end of the day, we're just organic machines. And obviously, patients are 100% completely in charge of their own organic machine. One thing that has kind of helped provide some context for me and other providers that I talk with is, we're advising a patient. We're kind of like a mechanic, and or a, some people go to a mechanic to soup up their car, and there's a menu, and whoever owns that car can literally choose: I want nitrous, I want a turbocharger, I want a big wing on the back. And that's basically what a lot of these, executive physical programs are, or health optimization programs. You go in and you get the cookie cutter tests, and regardless if you want it or not, you're going to get it. So, you send your car off to the factory and you get souped up with all of these different. No matter what, you're going to get a turbo because this is just the package that they offer.
Mm.
And I'm, not even necessarily ethically against that, but obviously my model is different. But one of the helpful constructive feedbacks that patient gave us is they said, you're too much like a private chef. We want to see a menu of all the things that you offer: testing, therapies, etc., because we just want to talk about the upsides and downsides. When a patient comes in the clinic, it's very common they say, hey, I think my hormones are off, I'd like a Dutch test. Hey, I think that my risk of dementia is high, I'd like these genotypings. And our first question to them naturally is, well, why? And also, what's your understanding of the benefit and the downside of the test? Even if the downside is relatively low, we try to talk
Mhm.
about, yep, here's the upside, here's the downside, here's the limitations. And I think that that's a model that a lot of these clinics can do that just want to try therapeutic trials. If your car comes in with a noise and you're pretty sure that it needs, an alternator replaced or whatnot, I still think especially when it comes to our own bodies. You can't just buy a new human body like we can buy a new car. I think we owe it to patients to at least say, well, here's how we would find out before doing a therapeutic trial.
Yeah, it's a really interesting conundrum now because patients are so, we've had this democratization of medical information that used to be this physician only information, but now things are so readily shared between the internet, AI bots, like you talked about, building this AI doctor, and just social media, that you can learn so much that I think, one, it can be overwhelming for patients sometimes because they can't discern good information from bad information. But it also puts a challenge in the hands of physicians to, one, stay on top of information, and two, be open to having these kinds of conversations with their patients, because I think a lot of docs used to feel almost offended when a patient came in with a suggestion of, I think I'd like this. And in order to really survive, at least in this kind of primary care setting now, you have to be open to having those types of conversations. It's such an important part of the care that we're providing today. I love that approach. I'd love to hear more about that from you.
Yeah. That's why we named our clinic Individualized Medicine. Because at the end of the day, my opinions on functional medicine are great, but functional medicine has, often turned into cookie cutter medicine. And when you're starting out, it's fine to use more, templates and algorithms and this and that. And it's fine to use tools as well. That's why new providers use UpToDate very frequently. And AI is just going to be the new UpToDate. So it used to be you just, and for those who don't know, UpToDate is basically just the website. It's almost like Google, except doctors and NPs go there and then just look up whatever the answer is and then just do that. Has the dosings and everything, and you just pay a subscription. So there's nothing new with providers using these different, models for practice assistance. But the part of it's the podcast. This new order of conventional medicine versus alternative medicine is very interesting. I think it's good that there's a balance between both, because conventional medicine obviously has brought us a lot of benefit, but the credential matters less than ever, which I think is good. Credentialing is obviously important, and you should do medical training in some way, but people can listen to things like long form podcasts and they can discern the wheat from the chaff, if that makes sense. So, in the past 5 years, 10 years, there's been tens and thousands of people going to their endocrinologist and telling them, I listened to a YouTube video from More Plates, More Dates, or I listened to the Huberman Lab podcast, and I know I can do subcutaneous estradiol cypionate for my HRT, and I do not have to take equine estrogens. Or I know I can do, even as a female, I know that I can take low doses of testosterone cypionate, subcutaneous. And I know that I don't have to do whatever they were previously doing. So this access of information is good for everyone.
Yeah, and I think it certainly steers patients towards finding a provider that's a good fit for them and what they want, who has the education and training and maybe open-mindedness as well to really serve the patient in the way that they want. And I love the way you think about that, because ultimately the decision is the patient's decision, and I think it's our job to hold the boundaries of safety. But and I think about this a lot like parenting. We could have a little parenting discussion too, but with my kids too, it's like really our job is to hold the boundaries of health and safety.
Yep.
And if we hold those boundaries, we're doing our job. Otherwise, it's education, information, and helping the patients make the decision that's best for them.
Yeah, it's a good analogy. Partly depending on the age of the child too. So I guess you could say,
Absolutely.
maybe a brand new patient, you haven't developed that same physician-patient rapport. So the relationship does progress as you get to know them better.
So I want to shift back because we talked about hormones in men, but I know your population is not only men. So I've loved talking a little bit about kind of like the philosophy of medicine and information, because I think this is such an important piece and not something we've covered much on the podcast. But let's also pull it back to talk about hormones in women, because I don't want to run out of time and have not talked about that with you and kind of tapped in to your specialty there. So starting from the top, can you share a little bit about how your approach for hormone optimization is different for males versus females?
Yeah, certainly. So, I guess the first and obvious thing would be women are very likely to undergo menopause. And with males, you know, I talk about optimization and risk and benefits, even if they have, a technically normal total testosterone. With females, you're thinking more about area under the curve hormone and hormone sensitivity. So with males, you have a 3 times difference. One might have a total T of 300, one might have a total T of 900. That's about your variation. But with a female, both testosterone and estrogen levels might vary 10 times when you look at the area under the curve hormone that someone has. That's one thing that Dutch test is good for, is getting your idea of that area under the curve, because a single test, even if it's an accurate test, might be, difficult to interpret. Well, is that the spike? Was that a trough? Even if you know the cycle day. So the thing to keep in mind is some females might have a level that's significantly higher, but they might have less density and sensitivity of the receptor. So I would argue perhaps symptoms are, I don't know if I want to say even more important, but symptoms are especially important when you're trying to discern how that changes. The other thing is just knowing what assay to order. So free testosterone assays, not accurate in females, not that accurate in males, but free T is very not accurate. So I just like to have a total testosterone and an SHBG. If there is a early cycle, so early follicular phase estrogen, then you're going to have to order a sensitive estradiol, because immunoassays are not very accurate under 50 picograms per mil. Same thing after menopause. If you're not on HRT, your estradiol is very likely under 50 picograms per mil. So if you do an ECLIA and it comes back as 20, then that's very likely an overestimate. So you say, that's just something that the provider needs to keep in mind. The non-healthcare provider listening can just make sure that the provider knows that free testosterone assays and often estradiol tests, blood tests, are not accurate in females. The other thing that I think is important to keep in mind is most often, and this is not 100% of females, but most often they are better off starting some sort of bioidentical hormone before true actual menopause. Because what the classic way to do it is wait 6 months or 12 months since you haven't had any menstrual period, and you're basically menopausal for a while, usually with symptoms, and then you start the HRT. So even 10 years before, 15 years before, on a case-by-case basis, this is reasonable. The easiest way to tell of if someone's going to be more likely symptomatic in perimenopause is a DHEA sulfate. So if it's a high DHEA sulfate, then that's going to backfill estrogens and androgens. But if someone has a low DHEA sulfate, more often than not, they're going to benefit from premenopausal or perimenopausal hormone replacement. And then the last thing to keep in mind is, if there was one test to tell me, is this female going to have side effects from androgens or testosterone? Again, it is sex hormone binding globulin. It's not their testosterone level. It's not, some of it's their history too, if they have a history of PCOS. But SHBG is by far the number one thing that says, if it's too low, you are very likely to have side effects from higher doses of androgen.
And that's because you are saturating the sex hormone binding globulin. You're more likely to have more that's free and bioavailable to affect the tissue. Is that the thought behind that?
Yeah, that's a lot of it. The second part of that is, if SHBG is low and it's not genetic, it's almost for sure driven by a high insulin, both a high fasting insulin and that kind of area under the curve insulin. Just how much insulin do you have around at all time?
Mm-hmm.
Because when insulin binds the insulin receptor in the liver, that directly decreases SHBG production. And on top of that, after androgens like testosterone bind the receptor, insulin is going to potentiate that response. So think of it as a boost that makes your testosterone and your free testosterone even more powerful.
That's great. I'm glad you're sharing those. I want to dive into it a little bit more. And I would just offer maybe also that when you look at sensitivity to androgens, that the Dutch test offers another unique perspective there because we measure androgen metabolites of DHEA and testosterone. We measure 4 of them, which can help you understand metabolic preference.
Yep.
Which again, what we see is that particularly in women, the metabolite 5-alpha androstenediol, which is a metabolite of DHT, essentially. So testosterone converts to DHT inside the cell. It gets activated, but then it gets converted into 5-alpha andro before it can leave the cell. We measure 5-alpha andro, and we actually we're about to publish a white paper on this. I'll make sure we send it to you, Dr. Gillett, because it's really pretty cool looking at all the data that's out there, summarizing that 5-alpha andro is a better distinguisher of women who have androgenic symptoms. So like PCOS, hirsutism, acne, there's many others on that list. Androgenetic alopecia. There's a lot of models where they've seen that particular urine metabolite be very, very important. So again, we can measure that. And we recommend that providers think about that in baseline testing before putting women on any kind of androgen, because again, like you'd mentioned with sex hormone binding globulin, it's another way to tell whether a patient will be very sensitive to the androgens you put in the system or not so sensitive. And sometimes you can't measure it because you're not seeing that in the testosterone. You're seeing that in the metabolism, where the metabolites are multiple times more potent than testosterone.
Yeah, this is one reason why a lot of females are more sensitive to testosterone cream specifically, especially if they apply it in the pelvic area or in around the labia. 5-alpha reductase is much more active in that tissue. So it leads to, yes, high levels of DHT if you're not on dutasteride. And for women who do not plan to become fertile soon, I am a huge fan of dutasteride, not finasteride, but dutasteride, but just in low doses. But it also leads to 5-alpha reduction, like you mentioned, of many other hormones. This is why a lot of females are sensitive to DHEA. It's eventually going to be converted 5-alpha reduced, 3-alpha reduced to stronger androgens. The other thing about SHBG is you are going to metabolize some androgens faster. In general, the 5-alpha reduced androgens. So it's going to lead to higher levels of urinary strong androgens.
Great. Well, the last topic I want to cover in our last few minutes is around some of the foundational drivers of hormone dysfunction. Because you talked about the importance of looking at root cause. And I think that's, we really align there. What are some of the underlying causes of hormone dysfunction in men and women that are most often missed or that you see most commonly?
Yeah. Earlier, we mentioned that metabolic syndrome, which includes diabetes, insulin resistance. Very common. That's number 1. And then sleep apnea is number 2. Although sleep apnea is sometimes missed. Sometimes people say, "Oh, well, I don't have any symptoms," but it's reasonable, even if you're not sure if the symptom is due to sleep apnea or a low testosterone or cycle irregularity. It is reasonable to check. The main thing that I would say, both for males and females, especially postpartum females, is hypothyroidism or even hyperthyroidism, which is more common than people realize. So very important to get labs postpartum. And then pituitary adenomas, which are also more common postpartum. So it's basically common to have your thyroid hormone fluctuate up and down before, during, and after delivery. And it's also more common to grow this area of the pituitary. Pituitary is basically a small area in your brainstem that produces a lot of important hormones: prolactin, growth hormone, LH, FSH. And it's pretty frequent that someone comes in that has had symptoms or signs of hormone dysfunction, and they end up having a very small pituitary adenoma, not large enough to affect their vision or their smell, which are kind of the classic direct symptoms, but enough to affect their hormone production.
Yeah, great. Well, I really appreciate you joining me on the podcast today. It's been wonderful to have you on the Dutch podcast. I've learned a lot, and I'm sure our listeners have as well. If people want to learn more about your practice or about you, what are the best ways for them to find you?
Thank you. My pleasure. My Instagram is Kyle Gillett MD, Gillett Health, all other platforms, Gillett Health Podcast on pretty much any platform as well, and GilletteHealth.com. My AI robots and doctors and whatnot will eventually be posted on sagebio.com.
Very cool. Well, thanks again. And thanks to all of you listening. I hope you plan to join me every Tuesday. You can follow us, the Dutch Podcast, at anywhere that you stream podcasts today, and also at Dutch Test on Instagram and all of our other platforms. So thank you guys so much, and we'll see you next week. If you're wanting to learn and really expand your expertise in hormones, you're not going to want to miss our podcast. So make sure you tune in each and every week for our new content.